You first,
During
please.
during doctors prepare for the second patients, I'd like to briefly mention about the management of thyroid cancer.
Okay, thank you very much. I think you can share your slides. Yeah.
Yeah. The thyroid cancer originating from thyroid follicular cells are popularly follicular, poorly differentiated, and anaplastic cancers. Clinical course and prognosis are different according to cancer types. Patients with papillary or follicular cancer show very good prognosis, showing 5-year survival rate of more than 90%. This graph shows the percentage of new cases and deaths caused by thyroid cancers according to cancer types. Because anaplastic
Professor Kim,
thyroid
we cannot find the slide.
I think it's here now. Can you see it?
Okay, yes. It's okay now. Please.
Many clinicians assume that most deaths from thyroid cancer are caused by these aggressive variants. However, because most new cases are papillary and follicular, the majority of thyroid cancer deaths occur in these patients. This is true despite the fact that the papillary and follicular cancer have relatively very excellent prognosis. Characteristics of the patients and tumor can be used to estimate risk of recurrence and the risk of disease-specific death. Older age, male, large tumor size, extrathyroidal extension, degree of differentiation of cancer cells, and presence of distant metastasis are features predicting poor clinical outcome. The intermediate risk and high-risk patients benefit from thyroidectomy to remove all traces of thyroid cancer tissue. Radioactive iodine is then used to destroy any remaining normal or malignant thyroid cells. The patients usually undergo radioactive iodine scanning approximately 1 year after initial ablation to ensure that all thyroid tissue has been destroyed with the initial surgery and ablation. Serum thyroglobulin is also measured during TSH stimulation for the radioactive iodine scan. The stimulated serum TG assay is more sensitive for the detection of persistence or recurrence of cancer. For the recurrent cases, we can use surgery, ethanol treatment, or radiofrequency ablation, or laser ablation for local regional recurrences. And for palliative surgery, radioactive iodine therapy, external beam radiation, IV bisphosphonate, or chemotherapy, or many kinase inhibitor or targeting drugs can be used for the distantly metastatic recurrences. Although over 75% of all DTC do well after conventional therapy, comprised of surgery, radioiodine, and TSH suppression. However, 25% of DTC do not respond to conventional therapy and show poor prognosis. Most of those patients have radioiodine refractory DTC, posing great challenge for thyroid cancer management. The treatment option for radioiodine refractory DTC are watchful waiting for minimally progressive disease and without symptoms and low risk of compression. But we can do local therapy for high risk of local compression of aerodigestive tract or central nervous system, or single distant metastasis, or lesions causing local pain. We do surgical resection, external beam radiation, radiofrequency ablation, chemoembolization, or bisphosphonate, and TSH suppression with T4. For the systemic disease, rapidly progressive disease, or symptomatic and life-threatening disease, or who have lesions without candidate to other local therapies, we do an anti-angiogenic multi-targeted kinase inhibitor or kinase inhibitors with reinduction of radioactive ion uptake, or conventional therapy may be applied for those patients. To summarize, surgery and TSH suppression is the mainstay of treatment, plus minus radioiodine therapy. Those who have radioiodine refractory cancers could be managed by different modality, but efficacy is very limited. Meanwhile, thyroid cancer incidence has dramatically increased over the last few decades worldwide, especially due to increase in detection of small thyroid, papillary thyroid cancer. It caused great controversies over the world because most of those cancers are clinically insignificant. Despite the marked increase in detection of thyroid cancer, mortality from thyroid cancer did not change significantly, suggesting a possibility of overdiagnosis. For this situation, American Thyroid Association recently recommended active surveillance rather than immediate surgery for patients with small papillary thyroid cancers. However, we need to show safety and efficacy of such approach by a prospective study to optimize management of thyroid cancer patients, and efficacy of local modality such as radiofrequency ablation or laser ablation for this small thyroid cancer should be evaluated in the future. Thank you for your attention.